Spoiler. Yeah. There you go. All right. So thank you for inviting me. So we're going to talk about Alzheimer's disease and other dementias. Next, no financial disclosures. Next. All right. So before we jump into the topic itself, which is Alzheimer's disease and other dementias, just want to, no, you go back, please. Is it going automatic? All right. So just want to take a second here to talk about aging and mental health, right? So, because there's not only dementia, so at least 1 in 4 older adults experience some mental disorder or mental health symptoms, such as depression, anxiety, or dementia. And this is dramatic because suicide rates significantly increase during the life course, and it's a dramatic increase. It's not a slight increase. So it gets as high as 48.7 per 100,000 patients. And just to give you perspective, this is 4 times the national's age-adjusted rate of, which is usually around 11 per 100,000. So this is very significant. If you stratify from 60 to 70, it increases. From 70 to 75 increases. And even beyond 85 years old, it's even higher, the risk of suicide in adult white males. So due to population aging, the number of seniors with mental disorders is expected even to double by 2030. And older adults are less likely, unfortunately, to seek treatment for mental health problems. And when they do, it's likely to be within the primary care setting. So I'm very pleased to have a diverse, multidisciplinary crowd, because one of you, like Dr. McGinnis mentioned, that he has encountered patients with, cognitive disorders, which is absolutely right. Many times you will experience firsthand these patients. So it's important to have a little bit of clarity on how to identify, what to do, how to refer, how to do kind of a basic quick cognitive tests to kind of make sure where the patient is and what can be done from there. Next. So dementia is a syndrome, okay? So it means that it's a collection of symptoms in which there's a, go back. Yeah, so there's a deterioration in cognitive function beyond what would be expected to be normal aging. So it's very important to understand that although dementia mainly affects older people, it's not an inevitable consequence of aging. So you're not, let's say you're not expected to develop dementia just because you're aging, okay? So if you're 65 or older, patients with 65 and older they have incidence of 10% of Alzheimer's dementia, which is pretty dramatic, because if you think that for example, in 2021, the prevalence of depression was 8.6% in adults over the age of 18. So 10% of the elderly or patients, not elderly, patients 65 and over have Alzheimer's dementia. So it's a very high incidence, but it's not mandatory. It's not that you're going to develop dementia just because you're aging, right? Because there's still 90% of people who don't have that. So currently more than 55 million people live with dementia worldwide, and there are nearly 10 million new cases every year. It tends to double every 20 years. So that's very important given the fact that we are aging as a society and our life expectancy has been prolonged thanks to a better control of other chronic diseases. So, you see heart attacks and cardiovascular problems, the mortality lowering by 7.6%, I think, the last 20 years, and then the Alzheimer's disease, increased by 140%. So that's very dramatic data. So dementia has physical, psychological, social, economic impacts, not only for people living with dementia, but also for, their caregivers, their families. So it's very important for us to be aware of that. Next. Okay, so how do you detect that? And does it mean that because I said that dementia is a global cognitive impairment, so everybody who is confused or agitated or not making sense and they're older, they have dementia? So of course not, right? So one thing that we need to rule out when you're assessing the elderly patient with confusion is delirium, also called encephalopathy. Because encephalopathy is an acute, sudden change in cognitive function in the context of an underlying medical problem that is treatable. So it's a reversible, right? So it's not dementia, because dementia by definition is progressive. And encephalopathy is reversible if you treat the offending cause. So delirium can be fatal, and it's the most frequent complication affecting hospitalized patients ages 65 and older. And the problem is it often goes unrecognized, because it's very hard, with all fairness, to, the first responders or the first people who have contact with it, be it the family member or ED physician or hospitalist admitting the patient. You don't know their baseline, right? So you see them there, sometimes psychotic, agitated, not making sense, obtunded, sedated. So how do you know what is it? So that's why you need really to follow kind of this protocol of doing a thorough medical workup, examination, history, because you need to see if this is a worsening from their baseline that is abrupt. Okay, that's the big difference between dementia and delirium. And there's overwhelming evidence for linking several treatable medical issues with delirium. And one of my favorite to discuss is the UTI. And I understand that sometimes psychiatrists and ID doctors or internal medicine doctors don't see eye to eye on that, and I'll explain you why. So because understandably, folks from other specialties will approach this in a, let's say, more pragmatic way, in a sense that you need to have some more objective data to define it. No, this is a UTI that needs to be treated, right? I understand. That's you have your guidelines and your policies, and you see, okay, so I don't want only to see the UA dirty or colonized, but I need to see someone saying that they have suprapubic pain or pain on the costovertebral angle or dysuria or increased urinary frequency or hesitancy. But guess what? Your patient is delirious or maybe demented. So they're not going to be able to tell you that. Oh, but I need to see fever. Well, you may not see fever because they're immunocompromised sometimes when they're elderly, right? So that's why there's overwhelming evidence that links UTI with delirium. And once you treat it, it's gone. Okay, so you cannot cure dementia from night to day, but UTI you can. So why not give it a try? Because I've seen firsthand-handedly a lot of patients, in Jerry's site to improve significantly once you treat that. I understand that, if you go to meta-analysis, it's not convincing data that will link otherwise asymptomatic bacteriuria with delirium. But when you look to the data, it's really not very convincing because, the design and, how they're going to address that, as I said, once patients are very poor historians, so it's still debatable in my opinion. Next. All right, so just to be clear, we're talking about delirium, which is encephalopathy, not dementia yet. So the onset of delirium is what? Hours to days. That doesn't happen with dementia. Unless you have, of course, a stroke, and then next day you have vascular dementia. Yes, but if you don't have a stroke, Lewy body dementia doesn't develop night to day. Alzheimer's dementia doesn't. Frontotemporal dementia doesn't. Global atrophy doesn't. So you're not going to have that unless it's really encephalopathy. So fluctuating and sundowning, even though you can see sundowning in dementia, but it's more typical of the delirium, definitely of the fluctuation of cognition and the consciousness. You don't see a decline in consciousness in dementia, okay? And with delirium, it's usually altered. The attention is significantly changed. Psychomotor, you can be hyperactive or hypoactive, so it's not very specific. You often see the reverse of the sleep-wake cycle. And then once it clears, it's reversible. Next. So let's talk more now specifically about dementia and about Alzheimer's disease. Next. All right, so a few things about Alzheimer's disease. So I know that the nomenclature sometimes is tricky because people will say, okay, what is Alzheimer's disease? Is it Alzheimer's dementia? Is this Alzheimer's? So is this what? Is this neurological? Is this psychiatric? What is that, right? So it's a fair question because it's a neurocognitive problem, right? So neurocognitive. Well, the organ of the brain should never be teased apart what is neurology and psychiatry. As a matter of fact, Wernicke and Freud, they were both psychiatrists, but at some point, we decided that those disciplines should, go the separate way, and there is this, separation, not a divorce, to the point that I'm board certified in neurology and psychiatry, even though I'm a psychiatrist. But in any way, so Alzheimer's disease is a brain disease, okay? So it's different from Alzheimer's dementia. So what is the brain disease? So Alzheimer's disease is when you have the the illness, the pathology, the presence of the senile plaques, which is a composite of these amyloid proteins that are impregnated in the brain, and also the presence of these neurofibrillary tangles of the tau protein. So these two main things, you probably saw in journals and everywhere, the amyloid and tau. So amyloid peptide, usually the 40 or the 42 type, when they start becoming impregnated in certain areas of the brain, they will cause neurotoxicity and deterioration of the brain function and death of neurons, actually, with atrophy. And then the tau neurofibrillary tangles that got also disseminated. So this is the brain disease called Alzheimer's disease. Okay, it's an insidious onset. You may have these plaques up to 20, 30 years before you have any cognitive deficit. So any of us can have the position of amyloid right now as we speak, and then only develop the illness, far beyond, the age of 60 or 70 or 80 or never. Okay, so some people will not develop that. So for example, if you get normal aging, right? People who do not have dementia, if you do a post-mortem, autopsy, you will see that a third of the patients with normal aging, with no cognitive deficit whatsoever, they have Alzheimer's disease pathology, the brain, right? Because they'll see the neurofibrillary tangles and they'll see the amyloid. That's why it's so debatable now, the research on, we need to target amyloid, we need to target tau to revert that. Okay, but reverting that, is it going to revert the cognition? So, right? So the studies are now addressing this, right? So what study starts first? So we know that the brain pathology starts first, and then the cognitive impairment will follow, but not always. As I said, a third of patients with normal aging will have the Alzheimer's disease, but not develop the dementia. And patients with dementia, now if you take the demented patients, 88% of those will actually, if you look into their brain, they'll have mixed brain pathology, not only Alzheimer's. So they'll have the neurofibrillary tangles and the plaques that you see in Alzheimer's. You're going to have a Lewy body it's a problem with the synuclein protein, which is a Lewy body dementia, or you're going to have kind of multiple microinfarcts. So the most common is to see a combination of the burden of these injuries in the brain. That encompasses 88% of all the dementias. Next. Next, please. Okay. So what to do? Okay, so I understand that it's a complex, insidious, slow onset, slow progression, non-reversible. That's dementia. Go back, please. Go back one, please. Thank you. So the patient is now in front of me, and I don't know if they have intact cognition or not.
At 1:15.
So they're asking me, because the daughter is saying that dad has been more forgetful, or losing things, and asking same questions, or the attention is not there, and having trouble kind of managing his finances. So you want to give them some sort of feedback. Well, of course, you can refer to neuropsych testing, or you can, refer to the neurologist, behavioral neurologist, or the geriatric psychiatrist. But if you want, just to give them some idea of where the deficits are, you can quickly in 10 minutes do a mini-mental, right? So you pull that, it's free. You Google it, mini-mental status exam PDF, and it's free. So you ask these questions with the patient and you give scores. So you say, what's the year, season, date? So you see that. So the state, country, town, city, hospital. So you will ask all these questions, and at the end you ask these, you have them kind of copying these tangled polygons there for visual spatial skill. Next, please. And then this is how you interpret. So let's look into the severity row there. So it's 30 points is the maximum, okay? So if you have from 24 to 30, previous please. So basically there's no definite cognitive impairment. If you go from 18 to 23, it's mild, and then 0 to 17 it's pretty severe. But of course you have to account for differences in people have different levels of education. For example, they may not be good at math, and you ask them to do serious sevens or to repeat stuff backwards, and they're not as good. So you have to adjust, and there's the education adjustment there. Next. Yeah, so and then that gives you a sense of, okay, so my patient got 24, and the interpretation says it's no big deal because it's not, previous please, it's not on the mild dementia. But still, if you see the column day-to-day function, 24, significant effect on the person's life, may require some supervision, support, and assistance even, because there probably some part of his cognition that it's pretty impaired right now. For example, a lot of forgetfulness or inability to see the time now in the clock, or other executive functions that we will discuss. So sometimes, the number is not necessarily too far off, but then the impairment on that specific area, it's bothersome to the patient. So next. So, and this is the other one. So I'm just spending time just to talk about these two basic ones that you can do from 10 to 12 minutes. Montreal is 10 to 12 minutes. Previous one, please. So then the MoCA. So you want to be able to see what area is impaired. Like, is it visual spatial? Is it naming or memory or attention? All of those. I could spend 5 minutes to tell you how to do this, but we can always go back if you find it helpful. If you know how to do this, I can tell you how to do it. Okay. If anyone wants. Next. But in either way, so there are 30 questions too, and that is, the test was published in 2005 by a group at McGill, very prominent folks, researchers in dementia in Montreal. So, and then same way as the mini-mental, you have the stratification there of the scores. But the difference of the MoCA is because it can really kind of narrow down more like the MCI. Sometimes the mini-mental is not very sensitive if the cognitive deficit is very mild. People can kind of get around with it, and the MoCA will kind of be more sensitive on detecting mild deficits like the MCI. Next. All right, so continue with the definitions. Now, what is MCI? So is this the same of dementia? Is it the same of mild dementia? No. So it's a mild cognitive impairment. So it's not dementia. Otherwise, it would be called mild dementia. So mild cognitive impairment is a different entity. It may or may not actually evolve to dementia. So because if you have, for example, the brain pathology of those neuronal findings in the brain that are the hallmarks of Alzheimer's disease, you may have MCI due to Alzheimer's disease. But guess what? You don't know, right? So you only know that you have a mild cognitive impairment. You don't know that you're going to evolve to Alzheimer's disease. And that's why, studies that I'm going to show you how neuroimaging could be helpful. If you see the metabolism of glucose being diminished, if you see, your mediotemporal lobe starting to shrink. So those things can be actually, anatomical and, functional markers for evolving MCI to dementia. But MCI, it's a noticeable or measurable decline in memory, but very little impact on day-to-day functioning. So the person is still able to drive and do things, but you or the patient or family members or trusted friends will say that they're not the same. Okay, but so more than so 12 to 18% of people ages of 60 and older have MCI. Okay, 12 to 18% of everybody who is older than 60 years old have MCI, and 10-15% specifically of the amnestic type, the ones who have more forgetfulness, will annually progress to Alzheimer's dementia. Okay, so it's not necessarily a predictor, but it can be, right? 10 to 15% of people who have scored that on that range of MCI on the cognitive tests will develop Alzheimer's dementia. And what is normal age in that? It's subjective memory complaints like the MCI. It can be annoying, but not disabling. Some problems with name retrieval, minor difficulties in recalling detailed events, but usually not too bothersome to the point that they're going to become dysfunctional. That's what the World Health Organization defines actually dementia. It's when they have a kind of the social and the functional impairment that it's disabling. Next. So the neuropathology, we said a third of individuals, so a third of individuals without dementia can have Alzheimer's disease lesions, right? And sometimes these lesions are so prominent that even meet criteria for intermediate to even high likelihood of Alzheimer's disease, but guess what? They did not develop the illness. So we don't know why this happens. So there are some genetic studies that show the ApoE4 allele. If you have that, you have kind of the familiar version of Alzheimer's, so you may be more sensitive to develop that, especially if you have another aggravation like high blood pressure, diabetes. Then you're going to get into that combined, mixed brain pathology that will push you kind of to the edge, and then you develop the dementia. So we mentioned that up to 88% of individuals will have the mixed brain pathology, and the microvascular infarcts predominate as the sole or dominant lesion in almost 35% of patients with dementia. So as opposed to Alzheimer's disease, Alzheimer's disease accounts for like 75-80%, but usually they're not isolated. That's what I want to say. So 75 to 80% of patients with dementia will have Alzheimer's, but not only, okay? If they have only one pathology, that's usually vascular because it's another physiopathology, right? So you had a stroke, for example, and then you developed that, in that area, you had a cognitive impairment. So it's not necessarily the same neurodegenerative disease that you have in Lewy body or Alzheimer's. Next. Does anybody has any question at this point? I know it's pretty dense sometimes. Okay, so we got it. Dementia is a syndrome. So in order to be dementia, it has to affect cognition. The effect is global, and there is a decline from prior baseline, right? So it's not the same as any, let's say, intellectual disability. Because okay, so you get a person in your office, 65 years old, and they cannot write, or they're inattentive, or they are very forgetful, but you need to understand the baseline. Maybe they have a low IQ, or they have a developmental delay. Right? You can't assume it's dementia without knowing the baseline. And of course, delirium needs to be absent, otherwise you cannot detect dementia. Next. Yeah, these are just numbers, so we already discussed these numbers. Next. So, and then now the dementia then. So now it means that if you have Alzheimer's dementia, you have Alzheimer's disease, you have the brain pathology of neurofibrillary tangles and the tau proteins, and also the amyloid impregnated in your brain that is causing the dysfunction. So, but now you developed the dementia. It accounts for 50-75% of all cases of dementia, and it's low progression, irreversible. So what kind of cognitive dysfunction you're going to see to say, oh, this looks like Alzheimer's dementia, right? So you're going to see impaired memory, and very, very important impaired short-term memory. Sometimes it's very difficult to have them consenting for something, depends on the degree, because they will be so forgetful that it's not that they cannot understand, they will just forget. When you ask them to, talk back to you and say, can you explain to me what I just told you? They couldn't retain that information because the memory consolidation is, it's impaired. And also a lot of problems in executive function. And you see this in tests, in journals, in textbooks. Sometimes people don't know what necessarily is. So what is executive function? So executive function is the highest level of cognitive skills that someone can have. Okay, it's actually putting the skills together. It's to coordinate like the cognitive abilities of behaviors and working memory and flexible thinking and the controlling your impulses. So that makes you think in a way that is more sophisticated, right? So I'll give you an example. So someone with Alzheimer's have a deficit in executive function. They have a problem with the working memory. So you're consenting for a procedure and you told us, okay, Mr. So-and-so, so we're going to do this and we're going to draw this lab. And so you have any questions? They're unable to work, with their memory. Okay, so that's the working memory. They're not able to get that information and ask appropriate, meaningful questions about it. Okay, so that's the working memory impairment. So the cognitive flexibility, it's also executive function, right? So it's the ability of think of something in more than one way. Okay, so you say, okay, so, but if you don't want to do this procedure, sir or ma'am, so we can offer you this because that's another procedure. And they cannot work with the kind of the diversity of options, right? So if you make medicine for them an open menu, you're not going to go anywhere because they're unable to, reason between one and the other option because of the difficulty with the cognitive flexibility. Just trying to give you examples of what diminished executive function looks like. Also, the inhibitory control. So, you're talking to the doctor and you're having your own thoughts. So, oh, I don't believe that, or I don't think that's true, or, oh, I wonder if this can happen to me, or, you and I, you become, you quiet down those thoughts. And then if the doctor asks, do you have any questions? And then you're going to be able to politely rephrase that in a way that doesn't sound that you're antagonizing the doctor. But the Alzheimer's patient doesn't have the inhibitory control, intact. So they're just going to say, it's a lie. Right? And you're like, oh, what? Right? So, and that is the frontal disinhibition, right? So they have questions, but the way that they interpreted that, it's okay, it's not true. So therefore, I'm going to verbalize whatever comes to my head. So if you see like super sincere people, so just watch for that too. Next. All right, so this just separates by race and ethnicity. 14% of African Americans, 12% of Hispanics, 10% of non-Hispanic whites. And then there's still the dramatic increase that is expected from 5 million people with Alzheimer's disease to 14 million in less than 40 years. Next. All right, next again. Spoke about this. All right, the pathophysiology, again, accumulation of bad amyloid. I promise you're never going to forget this, right? What is the Alzheimer's disease? Oh, it's the accumulation of, you can even play fancy with your colleagues. Say, oh, it's accumulation of beta amyloid peptide and the neurofibrillary tangles, so the tau protein. So just want to tell you that it's a brain disease, okay? That may or may not evolve to dementia. And there are biomarkers, yes. So those two that you can check on the CSF. But also there's the biomarker, the ApoE, specifically the E4, that has been recognized as the strongest risk factor for sporadic Alzheimer's disease. Then you can ask why I don't see people ordering these things. Well, many times when you see them in the hospital, the deficit is already on your face. It's so evolved, they are kind of severe usually, and even terminal dementia levels. So this is more for kind of a mild cognitive that you want to know how this is going to progress, if it's dementia or not, type of outpatient workup. So there can be a lot of causes, right? So having this, having that. So while the causes of Alzheimer's disease are still being investigated, but there is consensus as where the neurodegeneration strikes first in Alzheimer's disease. So for example, the medial temporal lobe, and I'm going to show you some imaging here, mirror imaging. I don't want to embarrass myself in front of such prominent, radiologists, but just to tell you, there are some things that we can look. So it starts with the medial temporal lobe, and usually around the hippocampus, because the hippocampus is where you retrieve your memory, right? So that's the first thing that it's gone into Alzheimer's. So you have the volume there, it's smaller. And then as the disease progresses, and then you go into other areas of not only memory function, but attention and motor function. So that's why it's going to spread more in posterior cingulate and parietal temporal areas. So that's when you have kind of a more progressive illness with the kind of more generalized atrophy. Oh, Dr. Batista, but I've seen a lot of people with generalized atrophy not have Alzheimer's. Yes, that's why you need to start with, that's why I started with the mini-mental and the MOCA. I didn't start with the neuroimaging, right? So you need to have the context and the content together in order to deliver your formulation to your patient. Next, please. All right, so thorough medical history, of course, where the physician will document, current symptoms, the previous illness, the medical conditions, any family history of memory loss or problems with dementia. You may, of course, recommend a neuropsych testing right from the get-go because you don't want to deal with it, but I would, encourage you to do. So you have to see changes from baseline level functioning, okay? So just ask that. And assess the independence with the ADLs. Can you go back? It's skipping automatically. Okay, so you have to assess, the mental status, see the working memory, judgment, all that. Then you can do, of course, you refer to a neurologist because they need to do a full neuro examination. Because I'll tell you, for example, when we're discussing quickly here on Lewy body dementia, what you're going to see in Lewy body that you don't see in Alzheimer's. So because of the areas that it affects with the disturbed uptake on dopamine areas, so you will have kind of movement disorders that you don't see in Alzheimer's. Okay, so and then you can do some lab work. Next. What kind of lab work? So first of all, when you start doing kind of complementary or extra exams, there's not only clinical and history, you have to balance what we can do and what we should do, right? So you use your best clinical judgment, considering that how the test results are going to change the treatment plan, for instance, because the diagnosis is clinical. But you still have a geriatric patient there. We have their idiosyncrasies and, so it's good to kind of rule out all the things, of course. So let's say you start with your CBC. Okay, so I want to see if there is anemia that could be justifying, the altered mental status or altered cognition. Because in anemia, you could see, megaloblastic anemia, so lack of B12, and then, it could justify some of this. You could see, depending on what psych patients they're taking or psych medications they're taking or neurological medications like Depakote or Tegretol for their seizure disorder or as a mood stabilizer, it could cause thrombocytopenia. So you want to see that. So if they're taking lithium, it could cause a mild leukocytosis. If they take clozapine or Remeron, it could cause that, very dramatic, but thankfully very rarely, the granulocytosis. So if you do the chemistry, so what do you want to see there? All right, so I want to see their glycemic, panel, because patients with hyperglycemia, they get what? Agitated or comatose. Ketoacidosis, right? You can have delirium, you can have lethargy, and if it's hypoglycemia, you can have what? Agitation, have anxiety. So these things need to be ruled out. That would be in the realm more kind of the delirium, but also more permanent. If, someone with hyponatremia, they could have a cerebral edema, for what it's worth. So you need to make sure that you address these things before saying, this is dementia, and, this is going to progress. So do your homework, right? Like we all do. You do your CBC, knowing what you're looking for. Take a look at your chemistry. Is it calcium and magnesium normal? Because that can cause paranoia and psychosis. So is the liver function normal? Because if they're taking Depakote and the liver function is off, they could have hyperammonemia encephalopathy, right? So, and there is this serology test. Some people still order their RPRs or VDRLs, but honestly, the American Academy of Neurology says that it's really not a routine screening, unless the person has, history or whatnot. So we always check the TSH in geriatric patients with, especially with neuropsychiatric symptoms. Hypothyroidism can cause depression, as you know. Hyper can cause anxiety or even psychosis. And then the B12 folate, the homocysteine, if you see like the panel on the admission of a psychiatrist, you see, oh, they keep ordering this B12 folate homocysteine. Why is that? Just want to play fancy? We know that the B12 becomes more deficient with age, right? And then you say, oh, but you just said that you could see this with a cheaper CBC. You see the microcytic anemia, and there you go. You give them B12. They say, yeah, but the problem is the macrocytic anemia, it's it's a later presentation. In the beginning, you're not going to see that. So you're going to see, so maybe the B12 and the folate are going to be depleted first, and the patient is going to have cognitive problems. And then with time, the macrocytic anemia will happen. And sometimes, I wouldn't neglect giving that, repleting of B12 in patients with some sort of mild cognitive impairment, because sometimes you think it's not too far off. It's just marginally low, right? But then that's where you get the homocysteine, because the homocysteine, the B12 and the folate are needed to convert homocysteine in methionine. So if you see homocysteine elevated, it means that you don't have enough B12 reserves to get rid of that. Okay, does that make sense? So if you see elevated homocysteine, so you may need to give the B12 regardless. Right, next. So again, for those, outpatients that, if they ask because they're having mild cognitive impairment, they want to know a little bit more about the brain disease. They ask you, oh, is there anything that I can do? Right? Usually a neurologist will do that. So they can do a TAP and see in the CSF if they find those two markers of Alzheimer's disease, the beta amyloid protein and tau. So the increase in tau is more specific than the beta amyloid, because so the beta amyloid can also be impaired in the dementia of Lewy body. So it's less sensitive. So, but then if you have elevated tau, it's more specific to the Parkinson's disease. Next. All right, so now neuroimaging. So you can get a structural MRI to see the signs that I mentioned before. It was nice to see. So one day I had a patient in EDHS, and he was followed as an outpatient by another psychiatrist who called me and said, Dr. Batista, would you consider doing an MRI just to measure the volume of the hippocampus? I was like, very impressive. Oh, that's nice. My colleagues are, educated on that, and, they're following up on it. But the reason why I did it is because the patient already had pretty severe Alzheimer's disease. So I know that the disease is already, severe. So remember when I said that it starts in the medial temporal area, right? So that can be a good marker in the beginning for you to see, for example, the person has MCI and you want to know if there is more brain pathology. So you see that is shrunk. And then you can, okay, so this may predict, a worse progress. In all fairness, if you have MCI and you do a structural MRI to see the volume of the hippocampus, it's 10 to 15% smaller. So it is significantly smaller. But if they, as the pathology evolves, if it's Alzheimer's already dementia, so it's 20 to 25% smaller. Okay, the volume of the hippocampus. So that would be very helpful, I would say, for early diagnosis of MCI due to Alzheimer's disease specifically. So you could see if that is going to evolve, progress. or not. All right, next. So, and you can see that clearly there. So on the left, you have your normal patient. So we see those, so those areas of interest there, so the regions of interest there, they're outlined, right? So you see the right hemisphere in colors. So the hippocampus is the red, and the blue is the perirhinal. So it's a entorhinal cortex in blue. No, the entorhinal is blue and the perirhinal is the green. But anyway, the most prominent one is the red, okay? Which is where I said the medial, this area, this whole area is the medial temporal atrophy. So, and the red one is the hippocampus. So you see that it's intact on A, left, and then on the right, you have the Alzheimer's disease. You see how shrunk it is? So how lower the volume is, right? So you see actually like a hole there. Next. So, and then you have three there. So the left one, you have the cognitive normal, CN. You have the middle one, you have the amnestic, mild cognitive impairment, meaning the person has only mild symptoms, but mostly on the forgetfulness. So the memory is impaired, which is the most typical one that evolves to Alzheimer's. So, and if you see that area of the medial temporal lobe is, you see that the left one is intact, the middle one starts kind of, opening up. The volume is smaller, and the Alzheimer's disease one is even smaller. Next. All right, this is just volume again, non-amnestic, amnestic, and probably Alzheimer's. So you have the highest volume loss in medial temporal atrophy. Next. So more neuroimaging. So the FDG PET, it's a promising neuroimaging tool for diagnosis of Alzheimer's disease because it reflects the resting state of the metabolism of the brain, right? So we know that the brain consumes glucose, and if it's not at a basal level, it's not consuming enough glucose, so you have less activity on that area. So it's useful to distinguish Alzheimer's disease from, for example, frontotemporal dementia, that you would not have that diminished pattern on those areas: parietal temporal, posterior cingulate, medial temporal area. Frontotemporal would be more where? And the frontal in the temporal areas. So if you see those kind of being more diminished, you can see, oh, okay, based on the anatomy here, it would be most likely one versus the other. So the mean cerebral glucose metabolism has been found to gradually decrease with age. So at age of, when you're closer to 80 years old, it's like 26 to 30% less than when you're 18 years old. So you would see that with aging too. So there's a meta-analysis that I saw there where they got almost 30 studies on evaluating FDG PET in Alzheimer's disease, and they found like a good sensitivity of 91%. Specificity was 86%. So next, so this is the metabolism, and this is the amyloid PET. You probably heard of it. So there are several PET imaging tracers, right? So they're radioactive tracers. So the most common one is called PID, is the Pittsburgh compound. So these tracers will kind of, they get attached to the amyloid beta protein that exists, in those areas. So the amyloid image agents bind to the fibrillary forms of the beta protein 40 and the 42 deposits, and it will be providing kind of objective measures of the pathology, because now you see the amount of amyloid. But then the good question is, okay, but would that necessarily translate into cognitive deficit? No. I said, oh, so why am I doing it? Because it predicts how much the disease can progress. Okay. Oh, can I stop it from progressing? Well, we'll talk about pharmacology. There are some ways to kind of slow down, but not to stop. Next. And then these are the two types of scans that I mentioned. So the left one is the amyloid, the right one is the metabolic. So those top two, they're normal, and the bottom two, so they're Alzheimer's disease. Okay, so on the left, so it's going to be more amyloid plaques impregnated on those areas, and then on the right, you're going to see a diminished metabolism of the areas that are affected, starting with the medial temporal. Next. Right, well, this is just a summary of everything we discussed about how it progresses. Next. Any questions before we go to the tail end of it?
I got a question for you.
Yep.
Just real quick, I might have missed it, but did you touch on vascular versus Alzheimer's dementia, the difference in those?
I'll mention that. But yeah, but we can tell you right now. So it's basically, well, the aggravant, it's a vascular injury burden, right? So you need to have either like a recent stroke, a cabbage, endarterectomy procedure because or carotid stenosis, AFib, things that could be kind of delivering clots or causing microinfarcts to your brain. So that burden caused by the vascular injury would be what we call vascular dementia, right? So is it really dementia? Yes, because it has the significant cognitive impairment that impacts functionality, but it's not a neurodegenerative pathology that was caused by something impregnating into your brain and destroying your neurons like Alzheimer's. But then you ask, but how about clinically? Okay, if I go there and I see a lot of white matter, hyperintensities, I see kind of microbleeds, I see normal aging findings in my neuroimage assessment, not very specific, what to do. How it progresses. Alex, when you see someone with Alzheimer's, so you say, yeah, mom has been, getting worse for the past like 18 months, right? And then it's steadily worse. Mom is never like a month that she is actually back to her baseline or better. And that is not true in vascular dementia. Vascular dementia, the progression, it's called a stepwise progression. So you're doing okay, then you kind of miss a step, and boom, you'll go down. And then after that, we don't know if it's a mix of, vasoconstriction or vasospasms, or so they do worse. But then they recover a little bit, right? And then they do better again. And then they boom, get another, hit, and they have like a lower baseline now. So, but the studies are not 100% sure if they will always progress indefinitely like Alzheimer's do. Okay, does it help?
Yeah, that's great. Thanks.
All right.
I have a question.
So, yeah.
You mentioned earlier that there were disparities in how these dementias express themselves in different racial categories, 10% among non-Hispanic whites, 12% among Hispanics, 14% among African Americans. I mean, those numbers sound like they're not very different. Those are significantly different, 20%, 40% higher. Are there any insights as to why these dementias?
Why they're not very different?
Why they are so different, why there are these disparities between racial and ethnic groups. And
so there are some genetic studies trying to link, to specific ethnicities, but right now, all they could link was to age and social demographics. So unfortunately, 60% of the dementia cases are kind of in poorer countries, believe it or not. So I don't know if that is, and I wouldn't know how to explain that, because I would expect that, richer countries, you live in more because of less mortality on the other chronic illnesses. And then because of aging, you would be showing more. But I'm not sure why the ethnicity has been impacting that. That's a good question. All right. So I think we skipped the antidepressants. It's one slide before that. Yeah. So, okay, so why would I treat dementia with an antidepressant? Well, so antidepressants is just the name it's marketed. Okay, it doesn't mean that it only treats depression, to the point that it's the best treatment for generalized anxiety disorder, and they're not called anti-anxiety disorder, they're called antidepressants, right? So antidepressants, by the fact that they are kind of modulating the reuptake of serotonin, they can help in many other ways, as a with mood instability, with depression, also other symptoms that you see in dementia, like agitation, aggression, and even sleep disturbance. There was a study that I liked when I was doing my postdoc at MGA, and that was actually triggered me to go to psychiatry, not neurology, because I was studying, doing a postdoc in stroke, and I came across this study for post-stroke depression called the FLAME study, where people were using fluoxetine on the subacute phase of stroke, and people were improving even their motor function when they're recovering from depression. So it was pretty remarkable. So using antidepressants can be really helpful in dementia patients for a number of reasons. Also because then you are addressing a potential cause for cognitive decline, which is depression, right? So it used to be called pseudo dementia when the elderly have depression. If you and you guys have, depression, probably going to feel down. You don't want to get up next morning. You're kind of dragging your feet. You have very little interest in things that you used to have. Maybe even feeling kind of, what's the point of living, or being a little tearful and lack of energy. But then a lot of the elderly, they will not present any of these core symptoms of depression mood-wise. They will present a cognitive decline. So guess what? You treat the depression and you hope for the best. So when many people will revert back to their previous baseline. I've seen cases where we thought, is Dr. Hoy here? No. Jim Hoy? No. So yeah, Jim Hoy and I, we shared a patient in EDHS that showed a dramatic improvement that we thought was dementia with some depression. And we did a treatment, a rigorous treatment for her depression, even with ECT. Believe it or not, this woman went back to a baseline that nobody had seen in 15 years. So even Dr. Hoy said, it's amazing. I always thought that she had dementia. And, the family was so surprised. Imagine your mother woke up for 20 years, like a dormant state. So that was depression, right? So we can't underestimate the impact of depression in dementia. And there are many randomized controlled trials addressing the use of SSRI in geriatric psychiatry, supporting that. Yeah. So which one to use, Dr. Batista? Well, there's more data on escitalopram and citalopram. So as a therapeutic substitute here, because it's on our formulary, that's why I use more escitalopram, but you have to be cautious because, with other medications, it could prolong your QTC a little bit. But it's the most pure, let's say, SSRI when it comes to drug-to-drug interaction, because minimal interaction with the citalopram P450, as opposed to the Paxil, for example, or fluoxetine, Prozac, or Luvox, the fluvoxamine. You wouldn't use those in the elderly because they're more kind of dirty drugs. They have more kind of drug-to-drug interaction, so you want to try to avoid that in the elderly. Next. Antipsychotics. So that's a big topic in dementia, because if you hear antipsychotics, you say, no, there's FDA black box warning that you're going to kill the person if you give an antipsychotic. Well, you're going to kill the person if you let them get up agitated in the middle of the night, thinking that someone is going to come and murder them, and therefore they're going to hit their head in the floor. Then they're going to die. So given a low dose of antipsychotic to treat a severe delusional or paranoia or psychosis or very disabling and kind of emotionally disturbing hallucination is actually a very humane way to help people. So regardless of what the reason, is still the first line drug to treat psychosis, period. It's an antipsychotic. So what do I do about the FDA black box warning? Well, you do consent, right? So it's everything is, pros and cons. So it's this kind of lethal risk is based on, honestly, surprisingly unimpressive data, to be honest, because when you look into that, when each antipsychotic was studied separately, there's really no significant difference in mortality was found between that and placebos. When the data When you pull the data on thousands of patients, when they're combined, and then mortality was in some antipsychotics was a little bit increased, but it was so the group without antipsychotic was 2.6, and the group with antipsychotic was like 4.5. There's also another study that pulled together, several years of using of antipsychotic on patients with dementia. And let me tell you what, when you take into consideration the natural history and the progression of the disease, so look how reassuring it can be. So just the fact that you have dementia, your risk of dying in 6 months is 15.1%, okay? 15% of chance of dying just because you have dementia in 6 months. When you add the antipsychotic to the equation, it goes to 16.6, okay? So you really have to weigh risks and benefits. Of course, you're not going to treat with a high dose like you would do with a paranoid schizophrenic, unless the person has paranoid schizophrenia. And when you look into the data too, the most common cause of death, do you know what was it? It was heart failure and pneumonia, which, not surprisingly, are the most common cause of death in patients with dementia, either way. Next. And then you have the cognitive enhancers, so the donepezils, right, that you see a lot of patients with dementia on, the Aricept, which is a cholinesterase inhibitor, and the one on the middle row there, the NMDA antagonist. So the data, not going to spend too much time because we're running out of time, but basically you start with donepezil for mild cognitive impairment or dementia. And then as the disease progresses, if it's moderate or moderate to severe, you add the memantine. So the combination, the studies that show that the effect of the combination is better than either one isolated. Just watch out for patients who have kind of unsteady gait, because the donepezil can cause first-degree heart block, and in some cases that can cause more syncope and then falls and fractures. So if the person is very unsteady, I wouldn't use. And definitely if it's very severe already, so don't bother like adding these medications, because you're not going to revert to dementia if it's terminal or pretty severe. Next. So I was just this week reviewing the 2021 Alzheimer's disease clinical trial conference they held recently. The studies are not even published yet, just to give you a hint of what's going on now. So they're really targeting, as you would imagine, the amyloid and the tau. So the lecanemab, it's in a phase 3 study. It's a monoclonal antibody because it binds specifically to the beta amyloid. It's given IV and biweekly infusion. But that's why you need to read the studies, right? It's, oh my God, now it's binding the protein that causes the brain injury. And look at the outcome, the results. Look at the last line there. 90% converted into amyloid negative. Pretty impressive because it binds to the protein itself. 30% of, but then only 30%, look, it's not the reverted 30%, 30% of slowing on the clinical decline in 18 months. And also what's pretty impressive to me is I wanted to know how they chose these patients. 62%, the baseline was MCI. Remember the mini mental was 25.6. I said even that threshold that if it's 24 to 30 is even normal, right? So if you want to see more the deficit, the nuance of the deficit, like 23, 24, you would pick up on the MoCA. But so the average was 22 to 30 so they're pretty high functioning. I mean, in terms of their cognitive deficit, they're not bad at all. So it's really just very mild, symptom, which also you could argue, okay, but you should target when it's mild, right? Because the brain pathology you mentioned that it starts in the medial temporal and then will progress. That's right. So if you're able to revert in 90% of those cases to the point that the amyloid became negative, so hopefully if they do kind of more longitudinal studies to several years, if they can stop people from dying from it, then I would be surprised. But just 30% slowing on the decline, not very impressed. But I'm curious about what next steps are. Next. All right, so I promise very quickly now. So now instead of Alzheimer's is Lewy body. And the difference is instead of having those proteins, you're going to have the Lewy bodies present in the brain. differences. So, well, this is the third most common cause. So first is Alzheimer's, second is vascular, third is this. There's no specific cause, no family history, no genes. It's an alpha-synuclein protein that that is impregnated in those areas where the dopamine gets processed. Next. So I just underscore here what I want you to know about dementia of Lewy body, okay, is the take home. The alertness varies significantly. It doesn't happen in Alzheimer's. In Alzheimer, like I said, mom has been going worse for the past 18 months. That's all they have to say, right? And they will give you several examples how mom is doing worse. Fine. But then the Lewy body is kind of this weird thing because it doesn't even let people kind of to accept the illness. No, Dr. Batista, it doesn't make sense. You know, today she was fine. She was recognizing everyone and she was doing well. And then, you know, yesterday she was kind of, you know, sedated and kind of slow and not engaging. So this level of alertness, you really don't see on Alzheimer's, much more on Lewy body. The other thing, well-formed visual hallucinations. If you see that, it's very typical of Lewy body. Usually small things, interesting, small children being coming here and they're playful and they're walking around, or these small animals and bugs all around, right? So that's more typical of Lewy body because of the area. It's in the cortical, it's in the cortical cortex. It's in the occipital cortex or the visual cortex, okay, that you see the enhanced lesions. And also on the motor function where that's why you have also the tremors. Where is it? There, underscored Parkinsonian movements. You don't see that in Alzheimer's, okay? I say, oh, but how do I differentiate that in Parkinson's then? So, well, the timeline. So you see a patient who have some cognitive deficits and like the pill rolling kind of resting tremor here, or a little stoop position or stiff. So you ask the questions to the patient and the family. When did he or she started having these tremors? So, well, it was just, you know, this year. But then the cognitive decline has been much longer. So whichever came first. If it started with a cognitive problem and evolved to a motor, this is Lewy body dementia. If it started with Parkinsonism, and then as the Parkinson evolved, the person became dementia, needless to say, Parkinson dementia. Okay, so that's what it is. Some researchers is starting to argue whether they the same illness, but doesn't seem to be. Next. Then not going to spend time with that because I mentioned already. But just one thing on that left column there, the bottom, core symptoms, REM sleep behavior disorder. Okay, so people tend to act out their sleep, and it's pretty common. But it's common in many dementias, but more specifically in Lewy body. Next, and then these are the difference between Alzheimer's and Lewy body. We mentioned about, you know. The movement, the hallucinations, okay, the change in the alertness. And then the last, so vascular, next. Well, it's the second most common. And then we talked this underscore there, stepwise rather than smoothly progression, which I thank Dr. Dogon for asking the question so I could explain the vascular. Next, right? So how you diagnose that is the vascular burden caused by injury from a stroke or vascular brain changes whose severity and pattern could be kind of, you know, atypical for just a normal aging. So you have, you know, microinfarcts, you have the history of cabbage. We mentioned a few. Next. So last thing is how you care for people with dementia. Try to keep a routine. You know, they need to see familiar faces, you know, have a routine. Ask people to write down a list. So have them to do that if it's in the beginning. What are we going to do today? So we have this doctor's appointment, we have this and that. So, you know, comfortable closings, and be gentle with them because they cannot process the information as quick as they used to. In the beginning, I just want to point that out. It's very, very frustrating and hurtful because they have full awareness of what they can no longer do. And then you start the denial and the shame and the guilt and the embarrassment and the sadness, but many people will not verbalize that. So imagine how hurtful is it for them to be unable to do things as before. So avoid things that could resemble some judgment. For example, "Hi, Mr. So-and-so, I'm Dr. Batista. Do you remember me?" Right? And then you are asking to hear something like, "Of course I remember you. What do you think I am?" Right? So you say, "Hi, I'm Dr. Batista." You can introduce yourself as many times. You can say, "What time is it?" many times. You can say how beautiful the day is outside and it's not snowing anymore. "Well, I'm glad the birds are chirping and it's spring," kind of to reorient people. But, avoid the kind of patronizing, condescending thing, especially in the beginning where they're going to be very sensitive to that type of approach, because some days they're doing better than other days. And, it's just very frustrating to see you yourself losing the abilities. Next. So reassure, speak calmly, listen, respect the personal space, give some quiet time. Sometimes they will need to nap more during the day. And if you want for them to have a routine, you help them build the routine and you reinforce that. Right? Otherwise, you're going to bring your loved one to the doctor and say he or she doesn't want to do anything, just sit on the couch all the time. But listen, the volition, the go-to, it's actually compromised. They're not going to have that go, no go. Okay. So you sometimes have to be the one who offers the hand and say, "No, Dad, let's come with me outside. Let's walk." Okay. No, I don't feel like, no, let's walk. Okay. And then they will engage. Even if you put a crayon in front of them, depending on, of course, you're not going to patronize them, but if they are, pretty evolved, them, crayon and put, "Okay, it's paint," and you start doing, they will engage, but they're not going to ask to do things. Right. So kind of challenging in a good way and kind of keeping them, active. It's going to be very helpful to prevent rapid decline. Next. All right. So don't remember, I asked that. Next. All right. Healthy and active life. Next. Home safety, you have to look into these things, insert safety plugs and remove curtains and rugs and stuff that are kind of in the middle that are not unnecessary, and make sure to put locks, on the doors and things like that. Next. And then these are just some things that I find very, very helpful to share with caregivers and with patients, these websites, because they have very kind of objective tips on what to do and whatnot, and even kind of service for support caregivers, because a caregiver burnout is pretty massive in these situations. All right. Next, and we're done. Thank you so much. Sorry that I had to kind of rush sometimes. Appreciate everybody's attendance.
Thank you. Thank you for that address. I thought it was wonderful. I guess one of the things I was thinking about is, in so much of medicine now is about disease prevention, and whether it's, heart disease or type 2 diabetes, we're looking at things, risk factors that we can mitigate before the disease manifests itself. So when it comes to dementias, what is research showing about the ability to actually predict who might fall into a dementia? Has there been much success in that at all?
Predict who may fall into dementia?
Right. And if so, the only thing I've heard that might fight against some of these things is vigorous aerobic exercise, and
for whatever's worth
also
it.
for heart disease and diabetes and vascular dementia too, I bet. So, I'm just kind of curious, are people looking for predictors for this?
Yeah, so it's very hard to predict who is going to evolve, but that there are definitely protective factors, like you said. So when you do exercise, of course, you're accounting for a lot of the vascular risk factors. For Alzheimer's disease, I haven't seen necessarily, except for the fact that people tend to have a higher level of education or meaning if you challenge your brain more, it seems that the progression is not as quick. So that could be protective. So when you read more, when you practice like retelling, like you see something and then you will tell to a friend or a companion what you read or what you learned. So that type of exercise, it will enhance your cognitive flexibility, which is something that it's repaired, and also the retention of memory. So it's almost like you doing a workup for the hippocampus, right? And being exposed to kind of different emotions. So you will bind context and content into the entorhinal cortex, and you're going to expand that flexibility of your hippocampus. So those things that enhance it cognition, they may be able to help kind of diminish the progression, or at least the speed of it. Yes, there is data on that. That will prevent it from happening. I haven't seen it.
You know, I remember a few years ago just running into a friend and asked how he was doing, and he was lamenting his father's descent into dementia due to Lewy body dementia. And to be honest, I'd never heard of this before. This is probably 5 to 7 years ago. And now I hear about friends with loved ones suffering from Lewy body dementia on a very regular basis.
Yeah.
People are just more nuanced in their approach and how dementia is being diagnosed. And is that why we're hearing more about it? Or do you see a real increase in the number of people suffering from Lewy body dementia?
No, you nail on the head. It's pretty much kind of increased awareness and more sophisticated workup, and people being more sensitive to the nuances that not everybody has the same thing. That's why things have been changing in psychiatry and neurology. Instead of calling everybody kind of neurotic, oh, this is just a neurotic person. Now you don't use that anymore. Why? Because now you know what a personality is, what a personality trait is, what a personality disorder is, what a temperament is, what an anxiety disorder is, right? And so on and so forth, that sometimes you would put in the same bucket. Same thing would be like, oh, it's a dementia. So I was talking to a colleague in Brazil, because my grandmother underwent a surgery for her femur. She had a femur fracture. And then the surgeon said, oh yeah, so she's presenting a senile dementia, right? And I said, no, doc, this is just because of the tramadol that she's taking. I mean, she's not like that. And she said, oh, so no, I thought that they at this age, it's pretty common for her to be like, so, but then I take my time to kind of, explain a little bit, talk a little bit. So I guess, yeah, there's growing knowledge and more dissemination of the differences and nuances.
Thanks. I want to open the floor to discussion. We have a large number of people here attending today. Anyone have any questions for Dr. Batista?
Just don't ask why psychiatrists insist to treat asymptomatic bacteriuria, because we're over this.
Okay, I have another question. When you're consulted for evaluation of people who are considered to be having dementia, what are the most common reversible causes that you really are finding? I saw the list of things that can cause it. What are you finding as a first line provider? Some of the reversible things.
The typical encephalopathies that we see: infection, electrolyte imbalances, UTIs, septicemias, like PEs, or exacerbated COPDs with hypercapnia. Things like that. Pretty much anything that can put you in the hospital if you're elderly, because you don't have that reserve, that cognitive reserve that makes you flexible, right? That's why, a depression, instead of just making you tearful, is just going to make you demented or looking demented. So you don't have that cognitive flexibility anymore. So it's a very important question, because we need to raise awareness that it's a very delicate brain that these folks have. And sometimes it's very difficult for families to accept that not all the time, even though they are reversible, when you treat the offending cause, not all the time they go back to the baseline they would like to, okay? Because of that same cognitive inflexibility or more difficult regeneration of the brain. Sometimes they go back to kind of a lower baseline now. And you have to be very patient on explaining that to families because, it can be pretty upsetting. So, well, I gave you my mom who was able to recognize all the grandchildren and name them backwards. And now she comes home and she asks if I'm Mark or Paul, right? So, but let alone, grandma had COVID, she was intubated, she was in the ICU, she had, elevated lactic acid, she had, and now, so we are, as doctors and providers, we're thankful that grandma is alive, but then you have to be patient to explain to families why that cognitive reserve or deficitary as baseline. So that's why she's unsure she's going to go back to that baseline day one.
Thank you. Dr. Bodner.
Yeah, Dr. Bodner.
Are there any objective measures to inform the decision about when to take somebody's car keys away from them?
That's a good question. And neurologists like to play fancy with that. They're doing kind of these assessments to give them letters to take to the DMV if they can or cannot drive. I use, well, one, my best clinical judgment. I use the not very sophisticated mini-mentals and MOCAs, and I use neuropsych testings. One thing that I like to use, Bruce, too, is to order a OT eval. That sometimes it's underutilized, but it can be pretty valuable when giving you a better sense of the global capacity that the person has. Okay, because that would be another topic for 1 hour conversation of when to address capacity, right? So capacity is a task-specific cross-sectional assessment when you want to ask if the patient understands a specific thing, to see if they will understand traffic light, the nuances of turning right and left and managing themselves in the middle of the traffic and the highway. That would be like global, assessment that you would need these multifactorial assessments that I said, your best clinical judgment, your mini-mentals and MOCAs, neuropsych eval, or OT to see what's the ability to perform things that are used to be routine for them. I would get more data to support my decision.
Thank you.
Any other questions for Dr. Batista? Dr. Iyer, I see you have your hand raised.
Yeah, I was just asking, how frequently do you recommend fMRI in, assessing patients with Alzheimer's?
So I don't do that often, but there is a reason, because I'm skewed because I don't have a outpatient practice for geriatric psychiatry. If I had, I would say yes, I would probably use more. And because my general practice is adult psychiatry, so I don't see as many patients with early signs of dementia or evolving signs of dementia. And when they come to me on the elderly behavioral health service in the inpatient, they are already severe enough that we passed that phase where I wanted to predict where this is going, because it's pretty on my face already that I need more kind of to do damage control and have them being kind of peaceful in order for them to be discharged. But otherwise, doctor, I would use it more, because I would like to differentiate between, frontotemporal and Alzheimer's in some cases. I would like to see if again, what are you going to do with it, right? Okay, so answering your question, I would, if this is a mild cognitive impairment, just MCI, and the person wants legitimately and rightfully so know if they're going to evolve to Alzheimer's dementia. So then I would. If it's just to differentiate, they already have the dementia. Oh, is this Lewy body or Alzheimer's? Oh, probably wouldn't, because you would use the same donepezil and the memantine. So, and then if you do a low dose antipsychotic, they get agitated. If they get really worse, the neuroleptic sensitivity is also a core mark of the Lewy body dementia. So it's something else that I would like to leave as a take-home point for you guys. Lewy body dementia, visual hallucinations, fluctuation of the cognition, Parkinson's when it's progressing, and very sensitive to antipsychotics as opposed to Alzheimer's.
Great, thank you.
Any other questions? Well, I want to thank Dr. Batista. You did a wonderful job. You made something that is a board requirement actually Pleasure. I know I feel.
Glad to help checking that box from your,
I feel a little more grounded here. You know, I know it sounds ridiculous, but I saw a patient today with delirium and I thought she had dementia. Now I know the difference, you know.
mission accomplished.
It is. She was in horrible, horrible pain and she was 91.
Right, and then you expect, okay, so
Pain and the
probably
infection
you,
is probably was going, she's in delirium.
probably you should have dementia, you're 91, right? But as we said, most people, yeah. So again, it's not normal to expect that they have dramatic cognitive deficits just because of the age. It's an illness.
Excellent. Well, listen, thank you so much. For our attendees tonight, you'll be receiving an email from us tomorrow encouraging you to complete the post-educational survey, and then you will obtain the certificate that will be your certification that you have obtained this board requirement. It'll be my goal to get this archived material posted to our website by within the hour. That'll be my goal. I want to thank everyone for attending and look forward to seeing you at the next medical quarterly staff meeting.
Thank you.
Good night, everyone.
Thank you.
Thank you.
Thank you.
Good night.
Night,
Night, thank you.
Good night. Thank you.